Hello, good afternoon, or is it good evening, everybody? I'm Clare Tower. I hope I'm not too much of a disappointment for everybody who's expecting Alex. Alex is currently in Indonesia, and he asked me only a few days ago if I would come and give his talk. So this is a lot of slides from him, okay? So I'm a consultant obstetrician, have been since 2011, however long that adds up to be. I'm also an expert witness, so I see lots of cases from lots of across the country. And I was also clinical director and clinical head of division, and also lead for maternity transformation over in Manchester for about eight years altogether. Before I stopped doing that, I was unwell. That's another story. I had breast cancer, but anyway. So now my life is a little bit different, and I'm very passionate about making changes in maternity services. And what's happening at the moment, I think, I don't know how many obstetricians we've got in the room, but it's actually quite a difficult environment for us at the moment, I think it's fair to say. So we're going to cover very briefly where we are today, very brief overview of all of the reviews we've had so that everybody knows where we're up to, what's working, why isn't it working, maybe suggest something that might be the missing ingredient, probably the one thing we've not spent much time on, and then talk about, reasons for hope. And again, a lot of these slides, particularly about the AMOS review, are from Alex. So obviously I can't tell you what's going to be in the AMOS review because it's not published yet, but it's where we are. So about 10 years ago, well, 11 if you do your maths correctly, Jeremy Hunt made this promise. He called it the National Maternity Safety Ambition 2015. And there was a national commitment to halve stillbirth rates, neonatal death and maternal death and serious brain injury by 2025, set against the 2010 baseline. We've not made that, yeah. We have reduced stillbirth rates. They've come down, but haven't met the target of 2.5. We've also reduced neonatal deaths, but again, not met the target. Maternal death is a challenge. Unfortunately, that remains pretty static or slightly increased if you look at most recent data. Certainly nowhere near the halving challenge that we were set. So we need to kind of look at it in a bit more detail. This is the data. It's quite detailed graphs, but you can see on one side we've got the stillbirth rates and the neonatal perinatal mortality, and you can see a gradual drop, yeah, although I think probably some of it is starting to tail off. The maternal death situation is a bit more worrying. You can sort of see something over the top, but anyway, the bottom line is it's come down and then it's gone up a little bit again at the end, probably about a 20% increase over the last two triennia if you look at it in detail. I can't talk about mortality in detail without talking about the inequalities that we face. Yeah, so we know that some of the minority ethnic groups, so Black and Asian women, face and continue to face a higher mortality rate for both mums and morbidity for babies and mortality for babies. So we've done quite a lot of work and things are improving. So some years ago, we had a 5 times higher mortality rate in Black women for maternal death. That has now come down, but it's still double that you see in white women. So we've still got a lot of work to do. And you see the same when we look at the babies. So babies whose parents are Black or Asian face higher rates of preterm birth, higher rates of perinatal mortality, and also higher risk or higher rates of birth injury. Okay, deprivation again across the board increases your chances of having a poor outcome for both mum and for baby. So these deprivation issues are persistent and difficult to fix. We've also had, as Andrew mentioned, a huge rise in our caesarean section rate. This is very new data. It's published from the NPEU very recently in the last few weeks. It's caused quite a lot of interest online. I'm going to step aside a little bit. So essentially, you can see this this black line here is the UK or English caesarean section rate over the last few years. So about 10 years ago, we were running at around 25 to 30%. We are now on here 45%, and certainly anecdotally, it feels like higher on the ground. I don't think this has plateaued. Our unit is about 50%, and I think we're very similar to other units. Yeah. Obviously, when that happens, your vaginal birth rate falls. Yeah. So far fewer women are now having normal vaginal birth or any vaginal birth. And in fact, quite recently, I think the most recent year's data shows that most women now deliver with intervention, either through instrumental delivery or cesarean section. Yeah, the vaginal birth without intervention is now, is now in the minority. We have also seen a reduction, however, in HIE. So the top graph there shows a reduction in the referrals to MNSI. So MNSI, to those of you who don't know, are our external investigation body. They used to be called HSIB, so they investigate all babies born over 37 weeks who are at significant risk of HIE. So essentially those that have evidence of brain damage on MRI. And you can see the rates of referral to that have fallen over that time period. So we've seen this massive increase in caesarean section rate, but we have seen a fall in stillbirth, a fall in HIE risk, but an increase in maternal mortality. Okay, so that's where we are. So we've had this decade of reviews. The first published review was the Morecambe Bay, the Kirkup inquiry in 2015. That was followed by the Shrewsbury and Telford, the first Ockenden report, which was published in 2022, and I did contribute to that review. Kirkup went back to East Kent in 2022, and then here we are now. We're currently awaiting the Nottingham Ockenden review and the Amos review. So the most worrying thing, I think, for all of us is that between 2015 and 2022, essentially the findings were the same. So Kirkup went into Morecambe Bay in 2015, reported avoidable deaths, poor team working, pursuit of normal delivery, which I think you probably all agree is not there anymore, the closing ranks when things went wrong. In East Kent in 2022, he found exactly the same. And what's really profound is that for me, is that he did a review, wrote that review, and then said, I'm not making any more new recommendations because they're already there in the system. Yeah, I have nothing more to say. And he said, I did not imagine for one moment I would be back 7 years later talking about a rather similar set of circumstances. Okay, so it's quite chilling, I think, to think about that. So what does every review find? It's different units, different teams, different investigators, but it's basically the same, okay? Women report not feeling listened to. Safety concerns when reported by staff are overlooked or they're not reported at all, presumably because staff don't feel able to. Poor and disconnected leadership, toxic team cultures, the themes are very similar. Which brings us to where we are now in the summer of 2026, when we are currently waiting 3 major reports. There's the Thirlwell inquiry, which is the Chester inquiry following on from the Lucy Letby. The Ockenden report into Nottingham. So that was established in May of 2022. Some of you may have watched the Panorama a couple of weeks ago. I found that a really hard watch. I trained in Nottingham and my 2 eldest children were born in Nottingham, and I've just found it devastating to sit through that. And then we are expecting the Amos review sometime during the summer. As you've heard, it's just been pushed back again, but it is coming soon. I can't tell you what's going to be in that review. However, she has, in the interim, sort of put out interim statements, both reflections and impressions, which was in December 2025. That was a very difficult read. And then she put out an interim report in February of this year. I think probably the review is going to be very reflective of the contents of that interim review. I don't think there's going to be any surprises. So this is a bit different. It's a national review. A whole system approach, which is again different to the individual units that have been reviewed before. She's got information from many sources. So there were 9,000 staff submissions through an online staff survey. She spoke to 450 families, 11,000 women's experiences, 38 national leaders have been interviewed, and she's visited the 12 trusts that are part of that investigation. So what is she going to report? I don't have a crystal ball, but what we do have is what was in the February report. So listening and compassion, top of the list. So again, a lack of listening, a lack of communication, families and women feeling disregarded when they raise concerns, symptoms ignored. Defensive responses to harm. So families frequently encountered a defensive response, and that is the one thing that is guaranteed to make things more difficult for people, is if you're defensive. Systemic cultural issues, limited learning, and a real need for cultural transformation within the system. So prioritising compassion, being transparent and accountability. There's also a postcode lottery in care, so it depends where you are. Big variation in practice. In this world of national guidelines, and I haven't sat and counted our national guidelines, to be honest, but I know our maternity guidelines in our trust run to 150 separate documents, okay? Despite all of that, we see regional differences. There's also big resource inequality. So I'm really lucky. I work in a purpose-built maternity unit that was opened in 2009, yeah? That is not the case for many places across the country. Dilapidated and poor estate is a real challenge. There's a real need to change the way the system works to try and make this more equitable, so people have more access to better care, and it shouldn't matter where you live. We've also had big demographic and clinical trends. So we've talked a bit about caesarean section rate, but underpinning and maternal mortality, but underpinning all of that is the changing maternal demographics that we've got. So more and more women over the age of 30 are giving birth. The average age for having your first child goes up and up and up year on year. There's a shift in patterns. So obviously we're getting far fewer spontaneous vaginal births, and obviously caesarean section rates are massive. And if you compare that internationally, our caesarean section rates, we're the only country where the caesarean section rates are rocketing up like it is. Some countries have higher rates than us, up in the sort of 57, 60% mark, but none of them have seen that big climb, okay? And the question has to be asked, do we justify that caesarean section rate in the context of such high maternal mortality, relatively speaking, even though we have improved our stillbirth and neonatal mortality rate? So that's great and should be celebrated, but we've still got work to do. So inequalities, I've already mentioned. The persistent problem that Black and Asian families and women experience higher maternal and neonatal mortality risks, those socioeconomic inequalities that we face. There's the impact of racism and discrimination. So women from Black and Asian backgrounds report being treated differently on our labour wards and receiving different care. And again, this same need for a structural reform. There's also workforce and capacity challenges. Those of us that work on the front line will know maternity has a problem in that we don't have a standard rate of deliveries. We have peaks and we have troughs. So when we have the troughs, it's nice and quiet, but when we have the peaks, it's hard, yeah? And it's almost like we're in this continual cycle of peaks and troughs, and that makes the service difficult to manage. We often face staff shortages, so not enough midwives, not in the right place, no rooms, not enough theatre capacity. And that is what we struggle with on a daily basis. Women get asked to move hospitals because there's no neonatal cots, or there's no space for induction of labour, or no space for their caesarean section. On top of all of this complexity, we've also got women who are often sicker. So we're getting rising rates of obesity, and with increasing maternal age, that brings increasing maternal physical problems. Yeah, so higher rates of hypertension, higher rates of diabetes, all things that require more monitoring and more intervention than ever before. Workforce morale and culture is a big problem. There's relentless negativity and scrutiny. I can't tell you how this feels on the ground. You have to experience it. We feel under continued scrutiny, and there's an awful lot of fear just pervasive in the system, which obviously produces defensive practice, which is difficult in itself. And the facility and capacity constraints I've already explained. I mean, in our unit, we are continually increasing the number of caesarean section lists we offer. We offer planned caesarean section lists 7 days a week now. So she suggested 6 factors behind all of these difficulties and failures: capacity pressures, culture and leadership, racism and discrimination, poor responses and weak accountability, the quality of the estate and workforce. And these are the 6 categories that I think we can expect to see our actions in when she reports. So why isn't it all working? I mean, I think we could probably talk forever about this. We have had more than 750 maternal and neonatal recommendations in the last decade. I mean, that is just a phenomenal number of recommendations for a system to get their head around. We also, of course, have a CQC system. So all hospitals undergo CQC inspections. Last year, Henderson in the BJOG asked the question, well, okay, with these CQC inspections, is that meaningful in terms of morbidity? Okay, so he found no association between any of the CQC ratings and differences between severe maternal, neonatal and emergency caesarean section rates across any units that are marked as outstanding or good or requires improvement. So essentially, whatever your rating is, it does not associate with having an improved maternal mortality, or improved neonatal mortality, or a better caesarean section rate, whatever better caesarean section rate means. We've also got the Maternity Incentive Scheme. So this is, for those of you who don't know, it's in simple terms an insurance scheme that the trusts pay into. So obviously maternity, because we are the highest risk in terms of litigation for both volume of claims and value of those claims, we make up the largest sum that the trusts will pay into the CNST scheme. Yeah. Maternity Incentive Scheme was introduced by CNST to incentivise trusts to make improvements. So for the last, I think it's since 2017, there have been 10 standards, apart from this year, it's just changed, but 10 standards that trusts should meet. Yeah. Essentially, the way it works is the trusts pay an extra 10%, so they may be paying several million for their insurance premium, and then they pay an extra 10% into the scheme, and then if you meet the 10 standards, you get your 10% back. Yeah. That 10% then generally goes back into the trust coffers. It doesn't always, in fact, it virtually never makes its way into maternity, but that's another matter. So if you look at the maternity incentive scheme, the obvious question is, well, is it improving safety? And what we found is that more than 80% of trusts consistently report meeting all of the 10 standards, but there is absolutely no measurable difference in outcomes to patients across those trusts. Okay, so despite all this work, and believe me, doing this is a lot of work, it's not improved anything. Okay, there was a review conducted by this institute to ask those questions. Well, what's the experience been? They went and asked all the hospitals involved, you know, has this worked? Has this been helpful? Essentially what happens is it gets maternity on the agenda of the trust boards. So that's a good thing, you know. I think so often in big trusts, maternity is played second fiddle to the slightly more exciting specialties that use robots or, you know, cancer or heart disease. You know, it's because it's maternity, it's tended to be not quite a big an agenda, even though having a baby, I mean, although we don't all have babies, we have all been born. So it affects absolutely everybody. Yeah. To say it's not important because it's just women and, you know, that's fake, you know, just women, which is, I've heard that said to me when I was applying for research fellowships. I was told, you're going to struggle, Claire, because it's just women and it's just babies. You know, that is what we're up against. So if it's anything that gets maternity on the agenda, it's great. Staff described that compliance was actually a great big industry. So it was really pulling time away from clinical care. And if you look at the 10 standards, I'll spare you the boredom of looking at them, but they are all essentially exercises and collecting data. Yeah, there's nothing much in there that really makes a difference. So my question is, did we just get really good at counting and trying to prove we were safe rather than actually being safe, you know? So what's going wrong? I've pilfered this. from somebody sitting here. So this is from Susie Crowe and Andrew Week's paper from the BJOG last year. And I think it's quite nice because it summarises all the challenges we've got. I've added the fear and mistrust on because I think that's the overlay to everything. So this kind of summarises everything we've got. We've got complex demographics, we've got societal change, we've got the influence of litigation, in particular the Montgomery ruling, which if you're not aware of the Montgomery ruling, that changed the way that we consent patients and made a massive difference to elective caesarean section, for example. The big focus on reducing stillbirth has increased our intervention rates, for sure, because the only way of guaranteeing you're not going to get a stillbirth is to deliver the baby, you know. And so that has increased induction rates. But obviously with that, we've had a rise in caesarean section rates. We've got all the staff issues that are going on, the shortages, having staff in the right place, staff being pulled to do other things, a massive amount of negativity in the media, which I think is really difficult for women and for staff. Yeah, it creates a lot of fear, a lot of anxiety. Things don't always get on social media portrayed in a very balanced way. And it means that there's a lot of mistrust. So the women often don't trust the service. The employees don't trust their employers. The whole system is just, for me, I'm sure I'm sure there are some people who look like they might work on labour wards in here, but it is the whole system. I think there's a palpable nervousness and fear there at the moment. We are over at the MRI, we're actually being filmed for One Born every minute at the moment. Which I think is fantastic, with the idea, you know, if we could just show people what it's really like and it's not all doom and gloom, I think it would be amazing. But sadly, so many staff have refused to be filmed. It's heartbreaking. Yeah. So I did a elective caesarean section that was filmed last week. And when you're in theatre doing a caesarean section, there's about 10, 15 members of staff in there, and I was the only person that consented to be filmed. And I think that just speaks volumes of how frightened the staff are. It's just such a shame, yeah, and that's where we are. So I've talked a lot about what's going on. The one area that I think hasn't had much attention is how do we improve the culture in our units? So is this the bit that we don't spend time on? There has been one attempt to improve leadership and the quality of leadership. So if you remember, culture and leadership has cropped up in all of the reviews, but it's the only area that's had only one strategy. So NHS England in 2022 launched this perinatal culture and leadership programme, which all trusts in the UK were tasked to take part in. And it was 3 phases, some leadership development, some culture diagnostics with the staff surveys, and then some culture coaching. They asked the University of Birmingham to do a review. Question is, did it work? So it worked at the very top, very briefly. So the idea was that they brought together the leaders in the team. So often one of the challenges we have is that we've got the doctors, the obstetric side, we've got the midwifery side, and then we've got the neonatal side, and then we've got the operations, the manager. And often one of the problems is those individuals work in silos. So when I was clinical head of division in Manchester, we had what we called the triumvirate, which was a lead midwife, me as the lead obstetrician, and then the operations manager, so the divisional lead, if you like. This brought in neonates into that triumvirate and called it a quad, and said, right, okay, if we bring these together in every unit, does it improve? So essentially, when they went away, they had an away day of training. When they went away and had that carved out time, then yes, it did. But unfortunately, when they went back into the units, it didn't translate, okay? And it didn't last. Why not? For all the usual things that we experience, yeah? So multiple problems. The quad members didn't fully understand the aims at the outset. It wasn't funded initially, so you can just imagine how that plays out. Turnover within the quad, so this is obviously a common problem. It's a lot of staff turnover, even in those senior leadership roles. Operational work pressures, so basically spending most of your time trying to work out how you're going to deliver all the women you've got to deliver and the number of beds you've got. General lack of support from the trusts generally, so they didn't support the culture coaches, and a lack of resources. But the biggest issue was that it didn't include any behaviour change theory. Okay, so they tried to change leadership and culture without looking at probably the most important bit, which is building relationships and building behaviour. So I think we've become very good at measuring compliance, okay? But does compliance make you safe or make us safe? Well, I think the evidence is that I don't think it does, yeah? And we cannot keep doing the same thing and expect a different result, because that's what we've done for 10 years. So I'm really hoping that Baroness Amos comes up with something different. For me, one of the most important things is working on your culture, okay? It just makes such a difference. And I'm going to tell you a story now. And this is a true story. So I was on the labour ward as a consultant. This is just a few months ago. I don't know how many obstetricians I've got in the audience, but this is a CTG. Yeah. Nice wiggly heart rate. This is how we monitor babies in labour. Yeah. So usually that's monitored through the abdomen, through a transducer. It just sits on the pregnant abdomen. Sometimes you lose contact, so particularly at the end of labour, the head descends into the pelvis and therefore it becomes more difficult. So what we can do is put a tiny clip on the baby's head called a fetal scalp electrode, and that enables us to monitor the baby. We had a woman who'd been induced. The CTG had been completely normal. I got called in because they wanted me to supervise the senior SHO doing a von Tooves delivery. I said, yeah, that's fine. Yeah, walk into the room. There's the SHO, 2 registrars, very senior midwife, fantastic band 7 midwife who I've worked with for years and years and years. What had happened was she'd started pushing and the monitoring had stopped. So instead of this nice wiggly line here, there was nothing, gone, yeah? And I said, well, why have we got half an hour of no monitoring? And it's because there was no leads to connect the fetal scalp electrode to the monitor. So we've got a big unit. We deliver 9,000 babies a year. We've got 17 delivery rooms. There was not one lead on the unit. Well, they thought there was one left, but they couldn't find it. Yeah, one lead. Yeah, for the whole unit, couldn't be found. So I walk in and we've had half an hour of no monitoring. We pull the baby out pretty quickly. Baby's born in very poor condition with a pH of less than 7. So that's in the highest risk category for long-term damage, and goes to the neonatal unit. It sends chills through me now talking about it. I was so upset. Yeah, it was awful for the woman, awful for the midwife, awful for the doctors, awful for the father who has to stand and watch, you know. And so I went to the lead midwife on the unit afterwards and I said, why have we not got any fetal scalp electrodes? And her response to me was, oh, well, every time I try and order things, I have to, need 3 signatures just to order a biro. And the midwives don't look after the equipment and they don't tell me when it's lost or broken. Now, what does that tell you about a culture in a unit? I don't think our unit is any different to anywhere else. I don't think Nottingham is any different to anywhere else. I think it's the same everywhere. We work in constant scarcity. And if you think about that, those midwives who accidentally lose and break equipment, that's inevitable. It's going to happen all the time. It's not their fault. It just happens. They should feel able to say it's lost and not feel frightened. The senior midwife shouldn't be thinking twice about, I'm not allowed to order any leads for the scalp electrodes. Those leads cost £175 each. Yeah, that's it. And if you think, in my expert witness work, we have babies who have cerebral palsy, and those cases settle for 25, 30 million. And just imagine how much pain and suffering that includes for that family, for those doctors who experience it. I think this is another of Andrew's papers. Work-related PTSD is a problem in maternity services. 14% of midwives and 18% of obstetricians report symptoms that would be consistent with PTSD. And that has a knock-on effect to the way you function at work, because one of the things you do if you've got PTSD is that you avoid things and you struggle to communicate. Yeah. This is a real problem. So you could say on one hand, well, okay, not having a lead, that's just an operational problem. It's just somebody's not ordered the lead. But what does it tell you about what's happening underneath? Yeah. And that, I think, is where we need to work, because that bit is the bit we're not tackling. So how many of the operational problems are actually cultural or relational? Yeah. We always know the medicine. We've got fantastic evidence to know what works. But what's missing is civility, it's psychological safety, it's compassionate leadership, it's trust. Yeah. And those are the really difficult things to work with, because they're behaviours. Yeah. So I couldn't do this talk without talking about civility, very briefly. Civility, so essentially, if you are incivil, you are being rude, and that can not just be the way you speak, it's body language and facial expression. Studies have shown that incivil behaviour will reduce team performance by 50%. And I know I'm struggling for time, so I'm not going to go into this in a lot of detail. You can read the evidence, but this is important. Not only that, if you witness incivility, then your performance falls as well, okay? And I can certainly relate to that when I've witnessed it in other people, and I'm sure I've caused incivility, because let's be honest, you know, in a stressful environment on lay boards, sometimes we're a bit grumpy, aren't we, you know? What about psychological safety? So that means being able to speak up without fear of being humiliated or put down. And it affects not only speaking up about safety concerns, but it also affects bringing ideas to the table and being open about mistakes. Yeah. And we know from lots and lots of studies that if you have low psychological safety, you will undermine patient safety for sure. Okay. We know this. The National Staff Survey every year shows the same thing. Okay, you can't argue with this. This is NHS data. If you have got an engaged staff, you will have a lower mortality rate. Yeah, across the board. The staff survey in the NHS sadly has awful response rates. So there's your first problem, which guarantees people aren't engaged. Yeah, and also the data quite clearly shows that where we've got poor staff engagement, you've got higher mortality. In our unit, our trust today staff engagement piece of work and discovered that actually it was in obstetrics and gynecology had the lowest staff engagement. Okay, and I'm sure that's not just us, it'll be everybody. Yeah. So reasons for hope. Yeah, let's try and end positively, and we can have a bit of a conversation, because I'd love to hear what you think. So I'm hopeful for the review. Okay, it's the first system-wide review that we've ever had. And the thing that is really, really clear is that everybody cares deeply. Yeah. Alex said that what's apparent is that no unit is failing at everything. In every single unit, there are people doing good things. Yeah. And that's really important. There is a lot of good out there. We have done a lot of amazing work. There's growing recognition. In addition, there's growing recognition that relational leadership, civility and culture are important. And that's what we need to do. In terms of, we know that good care works, just briefly, none of this is new. We know from data from looking at optimizing the care of newborns that are born prematurely, packaging what we know into a package that people can follow works, okay? There's really good data from stillbirth work, so from the Rainbow clinics. So these are clinics that look after women who've had previous stillbirth, that if you provide that specialist continuity, you will get better outcomes. Yeah, so we know these things work. There's also just started this new safety monitoring system, which I think would have flagged the units with problems sooner. So it's called MOS, which is Maternity Outcome Signal System. Yeah. And essentially it reports data in real time. So one of the problems we've had is the data is so slow to come out. It's several years out of date before we've got it. This is a real-time model, so it will highlight when things are an issue, so that trusts get alerted. So I think this is really helpful as well. I can't give this talk without mentioning continuity of carer. So this is having the same midwife throughout your pregnancy journey. It's the one thing that has been shown to improve outcomes for those very good groups that need to improve. So the Black women and the socially deprived populations, big improvements if we can provide continuity of carer. It's been in the political system for a long time, and there have been numerous efforts to try and get this. And the last one was in the Maternity Transformation Project pre-2021, I think it was. And sadly, in 2022, it had to be mothballed because essentially the staffing levels can't support it. Yeah. So, but if we want to improve outcomes for these deprived groups, that's what we need to do. So I do think there's a genuine passion for change, and there's a real opportunity. We've already got the National Maternity and Neonatal Task Force, who will be the ones implementing the change. It's becoming increasingly likely, I think, that we're going to get a maternity commissioner. And also, I think there's a real enthusiasm for changing culture. I really hope that this is going to be the case. We know what works, we just need to make it work. Culture is really difficult to change. I don't think you can do it by sticking posters on a wall with your values on and sending email memos, which is pretty much what happens. Yeah. There are a few models that are good, and one of the difficult things is it's difficult to have it as big a priority as it needs to be. Yeah. There's lots and lots of training on the what and the why about improving culture, but very little on the actual how, as we showed the culture work that's already been attempted. So we've got to work on that. What I'm going to finish with is this slide, and I think this is really, this guy, if you ever come across him, this is Professor Bob Claver. He's a professor of paediatrics down at Imperial. He runs a monthly session. In fact, I'm missing it tonight to be here, on kindness in healthcare. And he published an opinion piece in the BMJ. You might want to read it. And I'm going to read the last paragraph. Is what this asks of us. Every ward round, every clinical consultation, every leadership conversation is a small but powerful opportunity for all of us to balance relational practice with rational systems and processes that surround us. The evidence is clear. When healthcare systems invest in joy, kindness, compassionate leadership, patients do better and staff thrive. We do not need to wait for system change for that. We can begin now on our collective leadership challenge to reconnect healthcare with its mission and purpose. Okay, patients do not want to feel processed, which is what they feel like now. And I'm going to end there. Thank you very much for your attention. If you are interested in my LinkedIn, I post about 3 to 4 times a week on LinkedIn. And I also have just started something called the Trust Clinic, where we're working with healthcare leaders on an intentional way of improving trust. Yeah. Okay.
Thank you so much, Claire. Fascinating. I think there's going to be a lot of questions. Can we just get the camera on? I don't know if the camera working? It is working, is it? Okay, brilliant. Okay, so questions in the room first of all. Can we check questions? Is that okay? Yes, please.
Thank you, darling.
Okay, please.
Stephanie Miller.
Hello, thank you for coming.
I was very lucky. I retired my general nurse before I started my midwifery. So I was well rounded in taking care of patients at every level. You understand, obstetrics, medicine, surgery, all of that. And then when I did my midwifery, I was very lucky that I had a wonderful group of midwives who were grounded in the work they did. They were there for years, and they passed this wonderful knowledge and experience hand-on, but there's no substitutes in the world for it, from one generation of midwives to the next. The skill mix was excellent. That's everything. Skill mix, knowing who to ask when you need to know to ask and not to be afraid to ask. That empowers midwives. That empowers them. And that's why we have lost so much. And it grieves me when I listen to your lecture. Oh, unnecessary, the deaths of mothers and babies. I never lost someone another baby. I never did. I would be horrified at the thought of it. But we are losing so many mothers and babies now. It's like it defies belief, doesn't it? And I honestly think all the you know, facility, all the what's the word I'm looking for? All the what in the world will not help unless we go back to basic care. Good nursing care followed by good nurse and midwifery care, with a proper skill mix. The people know what they're doing and do it when it's necessary. Know when to ask the doctor for advice. Know when to ask the senior midwife for advice. Knowing when to call whatever, you are grounded and you have somebody there who will back you up and will.
That's fantastic. Thank you. People can't hear you online, so we're going to have to repeat much of this. So sorry to have interrupted. So the question is about skill mix and how this is something that we've lost over time, and how within the wards that actually having that good mix of people you can easily speak to, easily escalate. We had talk about escalation. Jimmy Walker spoke all about the difficulties of escalating care, which relates to this. So did you want to comment on that,
Yeah,
Claire?
I think that's a really good point about skill mix, and it's certainly something that the midwives I work with are concerned about, because we obviously have new midwives that come in and they need a lot of support, and there isn't always enough senior midwives around on the shop floor to give them that support, essentially. I also think escalation is a very important one. That repeatedly comes up in reports for sure, and how you escalate. And I think what's important is you need an environment and a culture where people feel comfortable to escalate, and they need comfortable to go and feel comfortable to ask for help, and they also need to feel comfortable, a bit like the example, they're worried about something. Yeah, and I think sometimes that hasn't happened, and people don't feel that comfortable to do that, or time pressures, they get pulled away, I guess. I don't know if you've got any.
Well, it's sort of paradoxical, isn't it? That people have been trying to get things right, and that means guidelines, it means good governance, it means actually pressure from above and making sure that people are doing the right thing. But that's odd, because then it's sometimes it changes in that people feel then fearful of making a mistake. They're fearful of escalating, fearful of showing weakness, which is odd, and it's not what people would expect.
No.
I guess one thing I should just say for people listening online, that the reality is that both stillbirth rates and perinatal mortality rates are the lowest they've ever been in history in the UK.
Yeah.
So losing babies, I appreciate that your comment, but it is actually safer from from a baby's point of view than it ever has been.
And I think what we have to remember is that these events are all rare. You know, they are rare events. Yeah. I think there was another question from.
Yes.
Yeah.
Yes, thank you. Of course, everybody agrees with you and with you. Tradition is very important, and culture is very important and stuff. But do you not think that the point is the woman's culture and woman's tradition during pregnancy is also very important? And I think this is even more important than the discussed traditional midwifery.
So the question is, well, it's a comment, I guess, is that we need to be absolutely. So the mother's culture and how they feel about their pregnancy is just as important as as that of the midwife and the hospital. Which I'm sure you'd go along with.
Yeah, I think that's what the question's about. Is, I guess, so pregnancy and birth varies across all cultures, doesn't it? And expectations vary, and that's actually, you know, is also one of the challenges we have, is that that's equally important, if not more important, really, than the system those women give birth in. And I think as our population has become more complex, some of that has probably become more difficult to manage. Yeah, I don't know if I agree completely. Yeah.
Okay, thank you. Let's keep going with questions. Yes.
Sum up in 2 words. Be kind.
Yeah.
Be kind to your patients. Be kind to your company. Be kind to yourself. People follow that, you know, follow granddaughter. Gets this very much in school, but it actually works. The kids are kind to each other. They don't have fights or the rest of it works very well. question is about racial discrimination.
Yeah.
Because people just say racial discrimination. It's always kind of assumed that it is white or an ethnic minority. My experience in medical practice is it's been very different. It's actually been one ethnic minority not getting on with another ethnic minority. That's an example being the Egyptian staff nurse basically refusing to work with the West African staff nurse to the point of actually ruling cardiac arrest. Yeah, and so and then on the medical side, it's been Indian doctors and Hindu religion not getting on with Pakistani doctors and Muslim religion. It's all been flying on the consultants being around. It's when they're not around that these things happen. Because I find it really strange in obstetrics that there's so much emphasis on this when a whole lot of obstetricians, a whole lot of midwives come from ethnic minorities. It isn't as though this was all the nurses, midwives, and doctors and white and all the patients were black. I think it's a really complex area here, and I think it would having a kind of blanket business about racial discrimination isn't good enough. We've got to get into where this is. Because I guess quite a lot of it is discrimination between staff, and that will then kick on into the patient care.
Yeah. Do you want to repeat the question? So that was a question about racial discrimination being quite complex, and I agree completely. It's not. It probably is a blanket term that hides a multitude of difficulties in the system. I think I wouldn't hazard a guess to try and understand it in detail, but it's something I discuss with some of my colleagues at work commonly, because obviously I work in a very ethnically mixed group of colleagues for sure, and it's interesting hearing their views on things, and it's I think it is very complex.
Sorry. Yes, please.
There's a model of care called the fact plus value model. And it links together the facts of disease with the values of culture. It doesn't keep them separate.
Yeah.
And I wonder if that sort of model could be applied, particularly around your area of how to put into effect that last slide you showed.
Yes.
Some of the changes that you want.
Yeah. No, I think
they're struggling to hear online. Yes. So do you want to
say?
Yeah. So there's a model of medical care where you try and bring together facts plus culture and pull them together, and often medical facts are dissociated from culture. And so saying how in maternity care, actually, those two need to come together.
Yeah, I think that's absolutely right. We've got lots and lots of systems in place that are focused very much on compliance. And unfortunately, I just think the culture side of it doesn't get the same attention. And so anything that brings the two together, I think it's the cultural things have got to be as important as those operational level things, because I think if they are, you probably find your operational difficulties will fix a lot quicker. Yeah, I'll have a look. Yeah.
Somebody called Fulford, apparently. Okay. I mean, it's an interesting quote, which I quite like, which is not always what you do, but how you do it, which is important. And I think we focused an awful lot in the past on guidelines and getting things absolutely right and making sure. But sometimes it's actually the kindness with which you do something. And that's often where you see birth trauma is not what was done, but how it was done. Sure. And it should be together, but surprisingly not always.
Yeah, I think there's good evidence, isn't there, as the way you are treated plays a big role. Yeah.
You take a question at the back.
And just wanted to hook onto that. What should we do versus how we do it? in other clinical specialities, we've seen over the past 30 years how adding pharmacists to the MDT has improved, particularly in terms of medicine safety. Now, and I just wanted your thoughts on how, or if you thought there was, it's worth considering looking at how pharmacists can help in terms of midwifery side of things. So even if that's education, that there's guidance that we're going through dissemination, or I just think that we can probably rethink how we've always done things to try and make things to utilise pharmacist skills in looking after patients, but supporting the midwives and the doctors who are actually at the forefront. And just when we get your thoughts.
So, a question from a pharmacist who's with us tonight, talking about how this is at Liverpool Women's actually, how we have a model where there's a pharmacist who's very much integrated into the multidisciplinary team, especially in maternity, and how important that is for creating a safety culture. Is that a reasonable summary?
Yeah, I think you're right. I think an MDT is really important. I think no individual profession can work in isolation. And I think the model of a pharmacist being, I mean, we certainly have a pharmacist on the that comes every day to the labour ward. We also have a microbiologist and we have obstetric physicians, so the MDT teams now, I think it's really well developed. It's good, and I think it's important. I often wonder how much input the community team get, because obviously a lot of pregnancy care is out in the community, isn't it? And I think that might, I suspect there is much less interaction because it's in the community, isn't it? But yeah, thank you.
Okay. Can we take a couple of questions from online? Because I see we're just coming up to 7, so we won't keep people, but lots of comments online which you can see here later. So let me just take the very final one, which is about continuity of carer, and saying how critical this is. It was identified as one of the key things to do, and it seems obvious that if you've got continuity of carer, then you can trust. You're going to build that relationship with somebody, and we can't do it. How do we move forward with that? It's very frustrating, isn't it?
It is frustrating. My experience with this, both because when I was clinical head of division, we tried to introduce it, and at the time I was also on an NHS England committee, the then maternity transformation team, and that also was looking at continuity, and it was the same issue everywhere, which was that they just didn't have enough midwives to be able to provide it. That was basically it. If you were going to put it in a nutshell, it was that. The midwives, people said, well, the midwives don't want to do it. But actually, midwives did if you gave them a model that didn't mean they were on call 24/7 and having to spread themselves too thinly, And that essentially is what it boils down to. If you can have a team of midwives so that, a woman would then see a small number of midwives rather than somebody completely different each time, and then have that midwife in labour, that would be phenomenal. For the staff satisfaction as well. On the uber rare occasions that I've actually delivered a woman I've looked after antenatally, it's just great, but it so happens so rarely, and I just think, if we could deliver that, it would make a big difference. Yeah.
But would take a big increase in staff.
It would take commitment and resource to be able to do that, and that will mean more midwives. Yeah, but we're training more midwives, but they can't get jobs. Yeah.
So final question is, somebody talks about the importance of trust and how a lot of the debate over the last couple of years has broken down trust. Yeah. Can I combine it with picking your brains about social media? Because often there's an accusation that social media is a cause of distrust. Yeah. You're very active on social media. Yes, how can those of us who dabble in it a little bit, is there a way in which we can contribute and help to the rebuilding of trust? Yeah,
I think so. I think there is a real dearth of sensible information online from people who are credible and have the qualifications to give it. There's very few of us. I can think of me and a couple of other obstetricians in the UK who are doing it. Out of how many obstetricians, I don't know. There's more midwives doing it. The problem we've got with social media, I think, is that the algorithms feed extremity. Yeah. So that means if you post something extreme, it will get lots, you know, and a crazy view about something, it will get more and more reward in the algorithm.
It's clickbait.
It's like clickbait. It's probably the proper way, but you know, anything extreme will attract more attention. The only way we can counter that is to try and get cleverer about the way we post sensible information, and it's a hard thing to do. You know, I've never been on social media until last summer, and the first time I posted on LinkedIn, I was terrified. I was like standing by the computer going, oh, but I just did it. And actually, it does. You know, LinkedIn is a professional forum. It's a whole different ball game to what you find in the wild west of TikTok and, you know, Instagram. But actually, my TikTok videos. So I make antenatal education videos. There's not a lot I can say in 30 seconds, but people don't have an attention span that's longer than that. But I try and, you know, and actually some of those videos have done really well and have had 50 to 100,000 views, you know, so it is possible. And the more of us that do it, then the better. And it doesn't have to be perfect. I think in the days of, you know, now we've got so much AI sort of rough and ready, actually it's probably more credible than highly polished and produced. Yeah. So I think if you are a clinician who's thinking, oh, shall I, shan't I? I would encourage you to start putting information out there so that we've got some counterbalance to the, you know, information, this sort of more extreme information. Yeah.
Okay. Well, I think we need to call it a day because it is 5 minutes past 7. Claire, thank you so much. Fascinating, insightful, clever. Actually trying to focus in on exactly where we can make change and how we make change, and it's so difficult to do. But thank you very much for coming across to speak to us. I would like to present you with a small token of our appreciation of your visit to Liverpool, and we hope you come again.
Yeah, and this gorgeous building. It's beautiful, isn't it?
Well, I'll take you around afterwards. Yeah.
Thank you very much, everybody. It's been great.
So thank you very much for coming. Thank you to all those online. I see there's been a big number online this evening. So thank you very much. Of this Bringing Life series, this is the final lecture. And in fact, my presidency comes to an end. And Dr. Andrew Drakely, who people may know, who's here, but people may know online as well, who's an IVF specialist in Liverpool, is going to take on the presidency from next year. So we look forward to a new programme next year, Andrew. And if people wish to become members, then please do come and join us. This is a fascinating place to be. If you're out of town, if you're a resident doctor, if pretty much anybody can join, nurses, midwives, £50 a year, and you get the use of this fantastic building. We ask consultants in Liverpool to pay a little bit more, and that's not unreasonable, although as soon as you retire, your rate goes down. So it's really very good value. So do come and join us and be part of this fantastic institution. Look out online on lmi.org.uk, and the details of next year's programme will be coming up. Those who are here, sorry you can't do this at home, but those who are here, please come and join us for a drink next door, and we can. I'm sure you'll be happy to take some questions then, Claire, next door. This topic will run and run, and actually the members who have had to sit through all this all year will be very happy to get back to something a little bit different next year. So thank you for joining, and we'll see you again.